We're live. Hello, everybody. This is Dr. Centeno again here, and another Facebook Live. As usual, and a little different today. Usually I give sort of a 10-minute brief talk about something, and then we open it up to Q&A. Today, we're going to focus on really a conversation with two neuropsychologists who happen to be married, who are sitting there in their home, because this topic of is it craniocervical instability or my neck or something in my neck or a concussion or brain injury comes up a lot. And both of these neuropsychologists are very experienced in working with patients who have had traumatic injury and many times have something going on in their brain and something going on in their neck. So I wanted to get them on today just to talk about this, ask them some questions. So Dr. Rusk and Dr. Schmitz are neuropsychologists. And guys, I'll just let you guys explain your training. What is a neuropsychologist for those who might not know?
Go ahead.
You go first.
Okay, so a neuropsychologist is typically trained as a clinical psychologist and get their doctorate in that field, and then spend 2 years in a postdoctoral fellowship position studying the brain and how it works when it's been damaged. If you think of neuropsychology as a combination of neurology and psychology, with the neurology being the hardware of the brain, the nerve cells, the chemical connections, the electrical connections, the blood supply, all of that is the hardware of the brain. And that's the neurology part. The psychology part, of course, is the programming, the software. So two people can watch a movie and have completely different opinions about what the movie was like because their software is different. So neuropsychology combines both the hardware and the software when we assess a patient.
Gotcha. So that's a great way to put it, because I think most patients think of psychologists as just the software, but you guys are also focused on the hardware, which leads into another question, right? So you guys do neuropsychiatric or neuropsychological testing. So what is that? Is that ways to test the hardware maybe?
Sure, and the software.
Both.
Neuropsychologists see patients who are starting to or have experienced a change in their thinking, typically because of some type of traumatic event. Automobile crashes and falls are the most common thing that can happen to a head that impacts the brain, makes it stop working right. Of course, there's poisonings, there's lots of different other ways. There's dementia, there's degenerative conditions. So there's lots of ways the brain can get hurt or stop working effectively. Neuropsychologists look at the patient, meet with them, meet with their family members, talk to them about what's happened, and then we provide them with some neuropsychological testing, which measures how their brain is functioning. You want to talk about how that gets measured with normative standards and things like that? Okay. So
I have a little different approach.
So brain function test.
Right. So brain function tests are, we've given tests to basically a big sample of the people in this country, and we've found out how they process each test, and we developed norms for those. So we know that if we give someone a memory test, we know that the average person is going to remember 7 items of a 10-item list. When we test a patient, we look and see if their test results are pretty much similar to what most people do, or if they're out of the norm. This is what medicine does. If you take your temperature, and we know that most people are right around 98.6. If your temperature is up to 103 or 4 or 5, we know that you're outside of what's normal and we can make adjustments to treat that. Same thing with neuropsychology testing.
And the numbers and the results of those tests look different depending upon, and the patterns look different depending upon the conditions we're looking at. So Dr. Schmitz was just talking about concussion or brain injury or slip and fall type injuries. Patterns of neuropsychological test results look very, very different if you've had a diagnosis of Alzheimer's disease or Lewy body disease, or you feel like you're getting some memory problems and you're not sure what they are. So we're really into pattern recognition, really, as detectives.
So that's an interesting one, right? Because I think a lot of people that are watching and are going to watch this are in this place where something's happening with their brain, right? They have some brain fog. Maybe they had a traumatic injury. They're not sure what's causing it. And they're probably afraid that it could be due to some awful disease that's more systemic and much more long-term. So can you tell from neuropsychiatric or neuropsychological testing the difference between, let's say, brain fog due to diffuse Lewy body or Alzheimer's and a traumatic injury? Is that possible?
Sure. Well, that's just what you were
answer.
saying. You want to talk about those patterns?
Well, there are neuropsychological patterns in post-concussion syndrome. Some of them overlap, right? So we might speak about different domains of cognition, like learning, memory, attention, and focus. And as your listeners are listening, it's important for everyone to kind of get a sense of what is my attention like, what is my concentration like, so that while we're talking, the listeners are getting a sense of their own learning capacity, memory capacity, if they're having challenges in areas of attention, focus, visual skills, spatial skills, balance skills. And the reason I'm saying, do I have trouble? Maybe people have difficulty planning and organizing or strategizing. I'm sharing that with you because those are the domains of cognition, of thinking, that we study and we look for patterns in. So, for example, in post-concussion syndrome, there's slowed speed of information processing, there's inefficient attention and concentration, and there's executive function tiring. So people really, it's a big strain to focus. They also have memory complaints. So there's some overlap, for example, in post-concussion syndrome or some TBI symptoms and Alzheimer's disease. But there are certain characteristics that would, for example, make Alzheimer's disease or Lewy body disease look different. Like in Alzheimer's disease, there's very rapid forgetting. People forget very, very quickly. And of course, we're generalizing because it's very, very deep work. But at least we're giving the listener a sense that patterns are different in different illnesses. And I'm happy you mentioned the word brain fog.
So let's talk a little bit about brain fog, because that's a big one, especially in this patient population. So maybe define that a little bit for me. You probably have a lot of people walking in with brain fog. So what is brain fog?
I'm going to get this question. Is that okay?
Sure.
Okay. So the reason I'm enthusiastic about this question is because I really don't like the term. It's a colloquial term that doesn't mean very much. It just means, geez, it means a lot to who is experiencing it, but it really is a difficult term to define operationally. It's not a scientific term. So when someone comes to us and says, I have brain fog, it's up to us as clinicians to really discern what that means, right? A lot of your patients probably say that as well. Mine do too. And you know, what I've learned is that sometimes brain fog is also the root cause of brain fog can be emotional or psychiatric. Like I just don't feel like my thinking is right. I don't feel like I'm in my body. And so I feel it's really important when you do have brain fog to go to a specialist to find out really what does that mean? Is my memory off? Do I feel like I have maybe a clouded veil in front of my vision and my visual fields are off? Because that could be true. Maybe I have a fever. Often people have brain fog when they're febrile. So I think, you know, and post-COVID, that term became very popular because COVID itself and sometimes the vaccination for people caused a blurred a blurred sense of I'm just not thinking right, which is really what it means to me. But
It's an altered mental state.
Yeah. But it's also a dissociative. Those are symptoms of dissociation in psychiatry and psychology, which is why sometimes it can have its roots in trauma or fear or anxiety.
So assuming all that stuff's been ruled out, because a lot of these patients go from specialist to specialist to specialist to specialist, and they still have something they would describe as brain fog. I'm assuming brain fog can be associated with concussion or many other injuries or other problems or diagnoses you guys see. So what would you do to try to say this is probably causing the brain fog? It's A versus B.
Great. You want to answer?
Yeah, it's
what we do.
oftentimes a process of elimination.
Yeah.
Is looking at the pattern of the patient's cognitive complaints, for instance, and what has happened to them. If they've been in a car crash, they may very well have sustained a whiplash or neck injury. And that can result in disequilibrium because the brainstem and the inner ear and the vision system are all interconnected with vestibular functioning. And that alteration of the vestibular system can cause people to feel like they have brain fog because they're unsteady. Their world is not steady. If they're in chronic pain, that pain in their neck or their head can also cause them to have a sensation of brain fog because they just can't focus on their job. So we really, and of course, they could have had a concussion itself, which is a diminishment of the efficiency of the brain. So we typically see people with concussions who have just an inefficiency, is what we call it. And that can come out in a lot of different ways. But in general, that's the main thing that we see with concussions is the brain is no longer working as efficiently as it was before.
So it gets tired.
So, and then there's the process of how the person's emotional functioning is. And so if we look at the combination of physical problems, that's the pain, the vestibular difficulties, the sleep problems, the neck instability, the cervical instability, and we look at the emotional processing and we look at the cognitive or thinking processing, we combine all three of those and we see how they interact with each other. So increased pain increases problems with psychological difficulties, increases problems with thinking ability, increased psychological problems cause increased sleep difficulties, maybe a greater concentration on our pain, and also cognitive problems. So that combination of physical, emotional, and cognitive domains is what we look at to determine what has happened to the patient and how we can fix them.
Gotcha. And then that brings us to our first question from the patients that are watching, and that is, what are the treatments that a neuropsychologist performs? So how do you guys treat these issues? Let's start with a concussion. If someone continued to have concussion symptoms and they're several months out, what can a neuropsychologist do?
Yeah, go for it.
You want to start?
Please.
Okay. So the reason we started a treatment division in our clinic is because we saw that treatment post-concussion really needed to be well organized. And we know, okay, so what we know is that people have cognitive, emotional, and physical challenges after a concussion, just as Dr. Schmitz said. So they need to be treated in all areas. We are not specialists in all those areas, so we refer to people like you who deal with pain. We refer to people who deal with other physical things, but we deal with the emotional and cognitive portion. And we treat with, sometimes people need trauma psychotherapy because the car accident or the injury was traumatic to them and it's hard to recover. Sometimes we use cognitive trainers because people are having challenges with the cognitive problems that they're having with memory, with learning, with executive functions. And so cognitive training, psychotherapy, we really have begun to love neurofeedback and neurostimulation. And we have a wonderful neurophysiology lab in our clinic because stimulating the brain with electricity, small, safe amounts, can be very helpful post-concussion and with memory problems. What am I forgetting?
Well,
Diet?
The cognitive rehabilitation does a couple things. One, it teaches people some compensatory and limit-setting strategies. So if someone has a concussion, what we might do is recommend that they reduce their involvement in volunteer activities, start to focus on just a few things. Instead of juggling 50 balls in the air every day, how about if you just juggle 20 and do those well? Because that'll keep you from getting so frustrated.
And the cognitive fatigue we talked about.
And the cognitive fatigue we talk about, yeah. So cognitive rehabilitation starts there, and then there are some brain exercises, some computer-based brain exercises that have been found to generalize to everyday functioning. It's one thing to be able to do games on a computer. It's another to see if by doing them, you start to really improve your life outside of the computer.
If there's like a transfer into your life, and
Exactly.
not all cognitive training does that, but in our cognitive rehab division, we're making sure that people are, it's very skill-based, it's also applicable to real life, as Dr. Schmitz is saying. The other thing that
we also sometimes suggest that patients start on a stimulant medication to increase the efficiency and the speed of processing of the brain.
But an important piece in the rehab process is sleep, Dr. Centeno. And so we do a lot of work helping people rehabilitate their sleep. The autonomic nervous system, our automatic nervous system, gets very, very upregulated after a concussive injury. And we need to do everything we can to calm the nervous system down and to calm the brain down and to think anti-inflammation. So we also make diet recommendations and some supplement recommendations.
Yeah, those are good points.
Okay, so here's a good one. For Dr. Rusk, how does brain injury affect sympathetic mode? Brain injury years ago, and I'm still jumpy for no rational reason. I also have trouble sleeping.
I am so happy
kind
for
of
that. Really happy for that question.
What's the nature of the brain injury? How did we're hoping the patient will talk about how the brain injury actually happened, because that jumpiness can be related to some trauma that occurred right at the injury. If that person was involved in a car crash or they were on a horse and a horse bucked them off, they may have developed a real strong fear response or trauma response to that injury. And that's why they're still jumpy. If they were assaulted, that could mean that they're uncomfortable walking down the street because they're afraid an assault will happen again. So it's really important to get to understand the nature of where the brain injury came from.
That's right. And sometimes the lingering symptoms, because a concussion or a brain injury isn't just biomechanical, right? It's autonomic, inflammatory, vestibular, metabolic, psychological. And so to answer the question, I don't know the nature of this person's injury, but I will say that it's likely that sympathetic activation happened, maybe because there is neck cervical instability, maybe because the vagus nerve was affected. This is all about, like, my special love. This person knew that, my real special passion project over the last 10 years has been the vagus nerve and the role of the vagus nerve in moderating and modifying our autonomic nervous system. And this listener is asking about sympathetic mode, which can very well be dysregulated because of the injury. And there are many things that people who feel agitated, dysregulated can do. First of all, find out maybe if indeed they do have still physiologic symptoms like increased heart rate, or check out your own heart rate variability if you have a smartwatch, or just do some vagus nerve stimulation exercises, either with a device or you can come to my vagus nerve groups.
And the purpose is.
And the reason I do my vagus nerve groups is because post-injury, during illness, post-COVID, there are many reasons the vagus nerve loses tone. It loses its capacity to be regulating for all of our viscera. And of course, the vagus nerve is talking to the brain much more than the brain is even talking to the body. So the body is always speaking via the vagus nerve 80% of the time. What's happening in the body? Am I safe? How are these organs doing? What's my heart rate like? How's my breathing? And the brain responds in kind 20% of the time.
So calming that.
So the invitation is to calm the vagus nerve. And there's so many ways now to be able to calm the vagus nerve. So I don't want to self-promote, but if you want to look on my website, you're welcome to.
Yeah. So I can put that in the description. But let's talk a little bit about vagus nerve treatment. So what would you do in a vagus nerve group as far as vagus nerve treatment?
Mm-hmm.
Well, I do a lot of practices on Instagram and TikTok. You'll see a lot of hacks. And hacks are little things that we can do to change our biology quickly. And I'm not a hacker. I want to say that I believe in slow medicine, the slow medicine of changing the autonomic nervous system, which is the vagus nerve's responsibility. And a big piece of changing the vagus nerve is being able to find breath that is calming, a longer exhale than an inhale, like a 4-6 breath where you inhale for 4, exhale for 4. There's some vagus nerve stimulation exercises that you could do to the tragus auricular stimulation, where you stimulate the ears, and these correspond to Eastern Chinese medicine points for regulating addictions and creating calm for people. So self-massage of the ear can be very helpful. Again, everything that tells the body that it's safe. And a lot of my work comes from polyvagal theory, which was developed by Dr. Stephen Porges, showing us that our autonomic nervous system is really wired for safety or for threat. So for example, this person who just asked a question, and many other people who have questions like this, are asking really about, why does my body not feel safe? How can I make my body feel safe again? So all the exercises that I offer, including us connecting well and self-regulating together with each other in community, co-regulating, can also help the vagus nerve feel better. Talking about it with somebody. There are also external devices that you do not need a prescription for. And there's one of them that I particularly like that I have on my website called Pulsetto. But I don't recommend a device without all the other things I'm talking about, Dr. Centeno. I think it's really important to stack these practices to make a long-term change in the felt sense of safety in the body.
Gotcha. So here's a question about exomind treatment or other forms of transcranial magnetic stimulation. Any thoughts on transcranial stim?
I do.
Yeah.
Funny you should ask. Funny you should ask. Well, I'm going to be opinionated, but I don't think you should do transcranial magnetic stimulation or any other kind of brain stimulation with anyone other than a trained professional, either a psychiatrist, a neuropsychologist, a psychiatrist, because what's happening now, and I feel badly for the public because the consumer don't know now what these devices are really for. And I think it's important, like I have patients who try these at-home devices, and I won't mention any names, and they're like, I felt really weird, that didn't feel good, it brought up an old trauma. So it's the same idea of as hacking. Now, TMS is excellent. Transcranial magnetic stimulation is excellent for depression.
In the hands of
the right. In the hands of, see, there's my partner right there. In the hands of the right provider. Some of these services are being offered in nail salons and massage parlors. And so I'm against that because I just don't feel as though it's safe or good, healthy medicine. And so I'm not going to speak to specific companies, but I definitely feel like you should go to the right person to get the right treatment. There are some things you can do at home, like not harmful. There are other vagus nerve stimulators that aren't harmful. There are many devices that aren't as strong, let's say, as transcranial magnetic stimulation.
Are you familiar with the exosomes?
I am.
Okay, do you want to comment?
Okay, well, so here's another one. Visual midline shift syndrome. We've talked with this group already about how that can be caused by input from the upper neck. Do you also see it with concussion TBI patients?
Sure. Yeah. And the overlap, like Dr. Rusk said, the overlap between CCI and concussion is very, very strong. It's a pretty overlapping Venn diagram. And so oftentimes we don't get so focused on, is it this or is it that? We pretty much recommend treating both, treating the instability, the cervical instability, and treating the concussion. And of course, the visual system, as I talked about earlier, with the vestibular system impacted by brainstem, inner ear, and the visual system. Same thing with visual midline shift syndrome and other conditions, convergence insufficiencies, and other visual problems. All of those things can be impacted when the brain is shaken around inside the skull. Remember, the brain is floating. The brain and spinal column or spinal cord are floating inside our body because they're floating in cerebral spinal fluid. And when there's an acceleration deceleration event, like a shaking of the brain back and forth, whether it's a fall or a car accident where you're hit from the side or back, things get shaken around and axons, nerve cells get twisted, sheared, torn, stretched, and that results in some inefficiencies of thinking and problems in the visual system and the vestibular system. And of course, due to the neck being injured also, it's the same thing. There's a lot of forces there.
Gotcha. So, we're approaching that 30-minute mark, and I'm going to give these guys 30 minutes so I can get to these other questions. But what would be a piece of advice you could give a patient who is struggling with what they've been told as is a concussion, and they're really not getting any better? What can they do next? Because usually, as you know, they've gone and seen the neurologist. They've probably been to a physical therapy-based concussion clinic. It's not helping. So is there a next for them in that vertical of treatment?
You go ahead.
No, you go.
Okay. Yeah, for sure. Certainly a neuropsychologist is something that I would recommend. We've seen we've seen over 10,000
getting tested, getting treated. There's something beyond just seeing the neurologist and going to the physical therapist concussion clinic.
And you know what? It's interesting because we don't even need to test. What I have found over the years, and Dr. Schmitz, you may not have heard it, said we've seen about between 11 and 12,000 patients already. So we really have experience with this population. And my sense is sometimes people don't even need testing. They need us to put the whole thing together, the psychology with the neurology, to appreciate the interaction and the integrative approach that we take, looking at emotion, cognition, and physical symptoms. Physical symptoms could be sleep. So it's that integrative approach that I think really is very healing for people.
Yeah,
and I really feel like neuropsychology does that well because of the integration of neurology and psychology,
sure,
structure and function.
Sure. Yeah.
And and the health of the nervous system, because many people come with sympathetic activation and anxiety. And sometimes that's physiologic, and it's sometimes old residue of trauma or brain injury.
Yeah, we often sometimes see professionals stay in their lane, which is a good thing, but it's important to have an awareness of other specialties that might be able to help the patient. So, for instance, physical therapists don't necessarily always consider that there is an emotional component, a psychotrauma approach that can be instigated and initiated for the patient. We see a lot of patients who no one has talked to them about their sleep, even though they've been to a physician a number of times. Sleep tends to be something that is not focused on. And so oftentimes we'll recommend some treatment for sleep, either medication or an actual behavioral intervention.
We're the integrative mental health and brain health people.
That's what, as again, neurology and psychology, hardware and software, that's where it really comes together.
Okay, well, that sounds great, guys. Thank you so much for spending the time on a Sunday morning, and I will put your information in the notes or the description for this video, so people can reach out. And you know, a lot of these patients are all over the country or all over the world, so you know, hopefully you'll have some resources for them that might be local as well if they're not from this area.
Guess what?
So we can treat people in other states too. 42 states.
That's right.
Our doctors are licensed in other states. So.
Gotcha.
But Dr. Centeno, before we close, I want to thank you, because actually we talk about you in a very just incredibly respectful and honoring way, and refer people to you because we feel like you're really just such a top-notch leader, and
Certainly.
We're so honored to know you.
And leader in the field of CCI especially. So thanks very much for inviting us, Dr. Centeno.
Okay, thanks, guys.
Okay.
Okay, so let's start getting to some questions. I did want to spend a little time interviewing two neuropsychologists for the price of one there. They're both married, if you could tell, and wanted to get some of those patients' questions answered first. And now we'll go to sort of the routine Q&A here. Do patients who have experienced relief from taking low-dose naltrexone or LDN have the same chances of responding well to a PICL? I don't see any difference. I think the biggest issue we see with LDN is merely that it creates a marked increased need for anesthesia, and that can create some issues. And then at some point, we have to get the patient off the LDN, meaning LDN is not a lifetime drug, or at least it shouldn't be if we can solve the problem. But I don't see a big difference in the overall outcome other than those issues. How much better is platelet lysate than Lysate PRP or D5W in treating nerves? Yeah, it's a good question. Platelet lysate is different than either one of those. D5W is going to have a little bit of a neurolytic effect, meaning it's going to calm down the pain component of a nerve, but not really help the nerve regenerate. Platelet-rich plasma can help the nerve regenerate, and platelet lysate can as well. So they're kind of in the same category. And then if we go to the next step and start thinking about the difference between platelet lysate and PRP, that's really going to be platelet lysate tends to be more anti-inflammatory and regenerative, whereas PRP can be more pro-inflammatory and regenerative. So that's the big difference there. Do you treat CCI 1C, alar ligament, transverse ligament at the same time? We treat a lot of CCI 1C, and we can treat the alar transverse ligament at the same time, as well as the many other ligaments that get treated with 1C. So 1C is going to be skull sliding on the neck. So you're going to have to treat that alar ligament to help that skull to C2 sandwich effect. Sometimes we'll pick up the apical ligament for the same reason. In addition to that, you've got to get the ligaments anterior to the 0-1 joint. The only way to do that is from the front. And then the ligaments posterior to the 0-1 joint And you can also treat things like the posterior atlanto-occipital membrane and nuchal ligament. So a lot going on in treating 1C. Hello, Dr. Centeno, you mentioned prolotherapy is 20% on the exterior. What's the success rate for external PRP? I'm not sure what that question is referring to. You may be referring to, just getting over a cold here, guys. This question may be referring to treating a type 2B craniocervical instability, or AAI, where C1 is sliding laterally on C2 due to a lax alar ligament. And it's going to be the same whether it's prolotherapy or PRP. It's only going to be about a 1 in 5 chance of helping that through posterior injections versus something like a PICL. So I think that's what this question is referring to, but I'm not 100% sure. Julie, I didn't get to this one, and I didn't think they would have a good sense of it. So I didn't think this was one that they would really be able to conceptualize, because they don't really deal with things like the impact of a retroflexed dens. I don't think a red light laser is going to get anywhere close to the medulla or the spinal cord, just because there's too much bone in the way. Nor do I think MLS lasers are going to work there. It's just not a good application for that kind of technology. Now, that kind of technology may be able to help with some of the more superficial problems, but it's not going to be able to penetrate through large bones to get into the areas of the brainstem or spinal cord it's going to need to get to. How long after hitting head and neck do CCI symptoms start? Usually pretty soon. But we also have seen patients who have a big injury, they seem to recover, and then they become sort of a camel's back, the straw that breaks the camel's back type issue later. So let's say they have an injury when they're younger, it kind of recovers, the ligament's a little bit more lax, but it's weakened, and then they get something else happens that isn't so bad and sort of pushes them over the edge, or the straw that breaks the camel's back. So we see that as well. Hello, Dr. Centeno, I get symptoms turning my head left, lifting my head up, and dropping my head back. My DMX showed translation C2, C3 down, but normal overhang. Where could the rotation symptoms be coming from? Could it be CCI 1 type 1C, or could it be the facets or the muscles? So if you get symptoms with turning your head, that's usually going to be more of a type 2B or rotational instability at C1, C2. If you get symptoms with dropping your head back, that could be more that CCI type 1C. And so that's going to be treating the alar ligament for the type 2B, and for the 1C, all the ligaments we've already talked about, but the ones in particular there would be the anterior AO ligaments on the front of the 0-1 joint. If your DMX showed translations at 2-3 but normal overhang, then it may not be a type 1C at all. It may be a type 3B, where C2 is going backwards on 3 when you bring your head back. So that's something else to look at, whether or not there's a CCI type 3B there. Let's see, isn't brain fog a symptom of CCI? It is a symptom of CCI for sure. Let's see, Mike, Dr. Centeno, what supplements do you recommend your CCI patients take while being treated with PICL? You know, Mike, we have a supplement that we recommend that we tested in our lab against live human cells. We spent about a year creating that supplement, and that's a supplement you can get at the clinic. Other supplements to consider might be taking after the procedure some omega-3 fatty acids, because they are rich in what are called resolvins, which can resolve inflammation, which we need to do to be able to get to the other side of inflammation towards actual healing. Other things that you might consider would be glucosamine chondroitin, but we have a supplement that we have engineered for this purpose. I think this may be a question for Dr. Schmitz and Dr. Rusk. As far as chronic fatigue syndrome, our focus is going to be on CCI. So if it's being caused by CCI, then we would address it. Ask that one. It's been advanced by Harry Winston. I was in an auto accident which caused concussion. That began my journey with CCI. That was now a few years ago. Can your treatments help years later? Yeah, the average CCI patient we see is usually several years out. So it's more rare, for example, for us to see someone only 6 months out. And then, so I'd say we have a peak at around several years out, and then we've got people on either end that are acute on the tail, and on the other side, obviously, people that are 10 years plus out. Let's see. If the vagus nerve is regenerating, is stimulating the vagus nerve going to heal the damage, or do we need Dr. Centeno's intervention? You know, I think everything should be tried short of the next step up, right? Which is always what I talk about. So there's a ladder of invasiveness. So for example, there are physical therapy techniques that some of the IPA physical therapists use for vagus nerve. That would be something great to start with. There are vagus nerve stimulators that you can try that are going to be a very low invasive thing to do. But if none of that's helping and you've got CCI, then the next step up would be those injections. That would be vagus nerve hydrodissection and treating the CCI. Let's see here. How do you distinguish if the symptoms are coming from cervicogenic headaches due to whiplash, or is it something else like ALR and anterior ligament laxity? My country doesn't seem to have a DMX. Yeah, so the first component of that is determining on movement-based imaging. So that would be flexion extension MRI, or even going to the YouTube channel and looking up the video on how to use regular X-ray to get DMX-like views. There's actually a video there that you can give to your local radiology center, and they can try to get the same views for us. And if you've got CCI based on that movement-based imaging, then we are suspicious that these symptoms may be coming from your neck. Now, obviously, you have to do a hands-on exam in order to confirm that. There are things we're looking for in an exam that tie those two pieces together: the imaging, the symptoms that the patient's having, and the physical exam itself. But the first step is getting that movement-based imaging always. M. Purple, Dr. Centeno, what's the cause for lumbar desiccated disc? Do they generate pain? What are some indications that pain is coming from disc versus facets in the low back? Desiccated discs are part of the normal aging process. They're like wrinkles on your face. So they don't necessarily cause pain. Now, they can indicate a sloppy segment, and we can look for clues, other clues, to see if that segment or that level is causing pain. So that might be clues on the MRI. Is the multifidus muscle atrophied at that level or intact? Is there swelling in the facet joint? Is the patient having nerve symptoms that are coming from that specific level involving those specific spinal nerves? And then a physical exam, can we again isolate that level as being symptomatic? Those are all things we would look at to determine if a desiccated disc were causing symptoms. Outside of that, a desiccated disc is just sort of a sign of wear and tear and aging. M. Purple, why would a 3 millimeter translation in flexion X-ray not show on a DMX? Yeah, I don't know the answer to that at all. So my guess would be but again, I can venture a guess. My guess would be that you probably got more flexion or were more relaxed on the flexion extension x-ray than you were on the DMX. So that's probably the difference there, meaning that when patients don't get full range of motion during a flexion extension x-ray or a flexion extension DMX lateral view, there's going to be a false negative rate, meaning that we know that about 25% of the time when we're doing these flexion extension images, we're not getting enough movement out of the patient to show the problem. So my guess would be is the first one you had enough movement, the second one you didn't to show the problem, and it was a false negative. Vero, is it okay to stretch the neck if we have CCI? What about isometric exercises? So isometric exercises would be generally better if you have CCI than aggressive stretching of your neck. Did I miss the neuropsych doc's tongue? How do they distinguish CCI from brain injury? Yeah, their focus is going to be neuropsychological or neuropsychiatric testing. And that's a battery of tests to look for patterns to see if it's coming from your neck. Is it coming from your brain? If so, if it's coming from your brain, what diagnosis does it fit best with? So that's really the focus there, is a test of the hardware of the brain called neuropsychological testing. And if you're in that rut of having a neurologist who has evaluated you, maybe you've been to a physical therapy concussion clinic, and you still have concussion-like symptoms, and you think your neck may be injured, then obviously you've got to get that evaluated for an upper neck injury, CCI or CCS, because that would overlap with those same symptoms. Having said that, if you think it's probably more your brain, then neuropsychological testing and seeing a neuropsychologist would be your next step. And I think that's the step that often gets missed. JS, if a person has autoimmune cancer, RA, or other kind of blood disease, does that affect the blood sample used for PRP or PICL? Is it going to reinfect the patient? That's a broad series of questions there, but autoimmune wouldn't make any difference, right? Whatever you have at spot A, you'll have at spot B. Same thing with other types of problems like that. As far as cancer is concerned, that's a bigger question. There are 1,000 kinds of cancer. So if we're talking about a blood cancer, that could be a concern for sure. And then as far as rheumatoid arthritis is concerned, PRP procedures seem to work well in rheumatoid arthritis patients, despite the rheumatoid arthritis based on the research that's been done. So a very, very broad question. Remember, we should only be using bone marrow concentrate with PRP and platelet lysate for a PICL, not the fake and bake Europe kind where they try to use PRP. So just want to draw that distinction there. Edgar, is CSC set up with DMX yet? And would you recommend doing it if patients are considering EPICL number 2 for lingering symptoms and improvements? Yeah, so we should be ready to go by January 1. I've tasked staff with that. We do have the machine in place. And so hopefully we'll be able to get all the testing and all the bugs worked out this next couple of weeks and get to early January start date. If you wanted to try to do a DMX just to follow up, we can certainly do that. But there really isn't a need to get the X-ray exposure unless we're looking for something specific. It's important to realize that any X-ray exposure, whether it's a CT scan, a DMX, an X-ray, should be looked at. What am I going to get out of that X-ray exposure? And we want to make sure that it's information that might change the treatment plan. JS, those suffering from CCI for years, maybe, is it possible they might have CCI trauma to cause a psychological problem and then they might need a therapist? Oh, sure. Yeah, we see lots of CCI patients that have been in pain for a long time. They've had problems functionally. Obviously, they have a hard time getting along with family members because they're in pain, because they're not sleeping, because they may have other issues. So seeing a psychologist is always a good thing if you think that that component has started to run out of control. It's also important to understand that I think many CCI patients become movement and fear adverse, and we don't want that when we start on the road toward recovery. We want to start moving more. We want to start doing things that we haven't done. And that's the whole rationale behind treatment. And I think, again, a lot of CCI patients tend to be movement and fear adverse because they've been told just by others or even in their head, if I move, I get more symptoms, so I'm going to stop moving. But we do need that movement to get better. Edgar, is type 2B considered AAI or CCI? C1 tend to rotate out of alignment with overactivity in patient or in PT, which ligaments should need to be treated. I had EPICL with about 20% improvement concerning number 2. It's AAI. Now realize AAI, CCI is kind of the same thing, right? If we're looking at the Venn diagrams from high school, you got the large circle is CCI, and then within the large circle of CCI, you've got AAI. And all AAI means is it's C1, C2. A type 2B is C1, C2. So a type 2B technically is AAI, but I don't care what you call it. You could call it CCI as well. I came up with a typing system because type 2B is now another circle within AAI. So it's much more specific, and it tells us where we need to treat. So for a type 2B AAI, which is part of CCI, we would want to be treating, for example, the alar accessory ligaments. And yes, it almost always takes more than one treatment for sure. Blessed beyond, do higher numbers and overhang measurements mean worse CCI, worse symptoms? You know, they really don't, based on what I've seen. We've seen people that are miserable with 3 millimeters and people that are only moderately impacted with 6 millimeters. So like many things in imaging, it's hard to tie the severity of what the patient experiences with the actual metrics and numbers. Blessed, do you ever recommend getting another DMX done after a PICL? We do. But again, as I was saying before, it's X-ray exposure. So we need to make sure that there's a question we're trying to answer, and that question and its answer will change the treatment plan. We don't want to get them just to get them because that's additional X-ray exposure, which is risk without benefit. Tactical trench, does the progress on PICL stay with you or does it deteriorate over time? We've basically seen progress stay with patients. Now, they can certainly ebb and flow as they go through the recovery, but in general, once they've attained that progress and it's stable, it generally doesn't deteriorate unless something else happens. And purple, can a whiplash injury cause arthritis and a disc bulge, or is it more likely to be age-related? Be either, for sure. You mentioned platelet dose is a king with PRP outcome. How do you calculate that for each patient? Yes, it's based on age and what it is we're trying to accomplish. So for example, for someone my age, 14 to 20 times concentrated in a knee joint would be great. You could get away with 10 times concentrated in a ligament. Now, if you take that and you apply that now to a 20-year-old, totally different picture, 2 to 3x. In both of those cases, will do just fine in a 20-year-old. So it's age and application based. Blessed beyond, what activities, movements can make 2B and 3B worse? Or do you see a flare in symptoms with certain activities for people who have these types of CCI? Usually rotation is going to make a 2B worse, based on what I've heard from my patients. And extension is going to make a 3B worse. So that kind of maps to those different types of CCI. Now, that's not hard and fast, because realize that sometimes motions in one direction will cause other issues. So for example, while rotation will make a 2B worse, many 2B patients say sometimes it's rotation and looking down, or rotation and looking up to a specific side. Okay, guys, looks like we're running out of questions here. And we're in our last 4 minutes. I do have to stop hard at 11 my time, just because I've got a breakfast coming up with my son here. Any other questions that I can answer? Here's a couple. JS, you recently said that repetitive prolotherapy should not be performed based on a clinic you made us aware of. Is prolotherapy and PRP different? If so, how many PRP or prolo sessions before stopping? Yeah, I think all I was saying there is I've seen certain clinics do what I believe is abuse this. So, you know, we would, when we did prolotherapy, we would do 3 or 4. And if the person wasn't better, it's time to move on. I've seen clinics, some clinics do 8, 12. That's really exposing the patient, in my opinion, to excessive risk. Now, you take that number and you kind of half it for PRP. So if there's a clinic doing a dozen prolo visits out there, then you should be able to accomplish the same in 6 PRP visits. Again, if you're not really noticing a difference after 1 or 2 PRP visits, it's time to move on to either bone marrow concentrate or surgery or something else. Have you heard the news about a neurosurgeon recently that successfully reattached the alar ligament? Haven't seen that one. That would be an interesting one to see. My guess is that would maybe be in a case of someone who had a traumatic, life-threatening dislocation injury, very different than the CCI patients that I see, meaning the CCI patients I deal with do not have life-threatening traumatic dislocation injuries. But certainly happy to look at that because that sounds interesting. Can you get 15 to 20 with an M-site setup? You cannot, no. Highest an M-site usually goes is somewhere in the 5 to 10x range. It would be very hard to get a 15 to 20x concentration reliably with an M-site setup. Let's see. Blessed, do you recommend Todd Ball's exercises after PICL or the exercises we have online? Start with Todd, and Todd can then help you work into the exercises we have online. Now, there are patients who are high level enough where they can sort of skip Todd and just go directly to the online exercises. But in general, it's good to have an experienced physical therapist who knows our CCI patient population working with you. So in that case, I'd say start with Todd and then go to the other ones. Okay, guys, well, I'm gonna have to start wrapping this up. Again, the first half, we talked to 2 neuropsychologists. The real take-home message there is if you're stuck and you think you still have concussion-related issues and it's either coming from your neck or it's still coming from your brain, obviously you gotta get your neck checked out because that's a very common issue. But if that is checked out and it's not your neck and you've been to see the neurologist and you've gone to the concussion clinic and you're still having issues, the next step is neuropsychology or seeing a neuropsychologist and getting neuropsychological testing the hardware of the brain. And that was really the point of this morning's interview with the 2 neuropsychologists. And then obviously answered questions. Let's see here. Thank you, JS, and thank you for everyone saying thank you here. I appreciate it. What setups get you 15 to 20x? $1 million lab like we've got. The Regenix machine is the only one I know. The Regenix actually has a kit that can get there, but you have to be a Regenix provider to do that, and we don't have any Regenix providers that are doing this work. They're not permitted because they don't have the training. So again, we've not trained anyone to do a PICL procedure. That's fiction if that's what you're being told. So it's either the Regenix kit can get that high or a lab, but those are the only ways to get that kind of concentration. Thanks so much, guys. Great to see you all here today. And I'll be back next week. I think I'm interviewing Todd Ball next week. I'm not sure, but I know he's coming up for an interview. So we'll do the same thing there. About 30 minutes of Q&A with Todd, and then I'll get into my routine Q&A. Thanks so much for taking the time today, guys, and I will see you next week.